Welcome, everyone. Thanks for joining us. Thank you for being here. Good afternoon. To folks that are joining us today, I'm just feels funny because I can't see folks' faces, but I can see the number going up in the as participants are joining. My name is Tanagra Melgarejo Pulido, and I am part of the National Harm Reduction Coalition, and I'll be one of the facilitators for today's training. Before I keep going, I want to also give a chance to my two colleagues and co-facilitators who are here to for them to introduce themselves and let you know who they are.
Awesome. Thank you so much, Tanagra. Hi, everybody. It is super strange not to see anybody's faces, but I know you're out there. I'm Taylor Edelman. My pronouns are he, him, his. I've been working for the National Harm Reduction Coalition for the past 3 years. I oversee a program here called the Lighthouse Learning Collective. You can find all that information on our website if you navigate to harmreduction.org. I'm happy to talk about it offline if anything seems interesting to you. But excited to be here. So Harmony, I don't know if you want to introduce yourself quickly as well.
Sure. Hi. Thanks everyone for being here. Harmony Seberg. I use she, her pronouns. I'm the National Program Coordinator at NHRC. Also been here for 3 years. And yeah, work really closely with Tanagra. I'm very excited to see all of you here today. So I'll pass it back.
Thank you, Harmony and Taylor. And if folks want to go ahead and introduce yourselves in the chat box, I can't see your lovely faces. As Taylor said, we know you're out there, but we also would love to know who is joining us. So if you can add your name, where you're from, and what part of the world or the country or its colonies you're joining us from, that'd be fantastic. That'd be super. So if folks have access to being able to add your names in there, that'd be great. And today's session will focus in the intersection of domestic violence, homelessness, and harm reduction. And this is a session that is brought to you in part through the Opioid Response Network. The Opioid Response Network is working with communities. This is a SAMHSA-funded project that assists states, organizations, and individuals that are by providing resources and technical assistance so that they can meet locally. They can support folks locally to address the opioid crisis and also stimulant use. The Opioid Response Network has technical assistance available, so we encourage folks to reach out to them. They do accept requests, and you will have access to these slides as well as you will have, because you will have access to the slides, you will be able to have a link there that you can click where you can connect with the Opioid Response Network so that they can connect you to your local technical assistance provider. I encourage you to reach out to them. They have many great resources at your disposal for you to be able to continue to build out the amazing work that you are already doing. So here is the information in terms of how to connect with them if you want to submit a technical assistance request. And Harmony is working on getting the chat enabled, so give us 1 second so that you can begin to introduce yourselves in the chat. At the end of the session, you'll have access to this QR code, which is an evaluation survey. It is helpful for us to get your feedback and to ensure that the trainings that we're offering are continuing to meet the needs of members in the community. Now for us, we're part of the National Harm Reduction Coalition, and NHRC has been around for 30 years. We are an organization that creates space for dialogue and action that help heal the harms that are caused by racialized drug policies. We do that through different avenues. Taylor, Harmony, and I are part of the BOLD training and technical assistance team, but we also have a great team that does policy and advocacy work, as well as a robust overdose prevention community-based project out in San Francisco, the DOPE Project. If you're interested in any of our resources or in any materials, we have so many things that we have built out through the years that are housed in our website. So I encourage you to visit our website to peruse it for any resources and publications that you may be needing. If there's something that you're looking for that you can find, you'll have my email. at the end of the session, you're always welcome to reach out to me. And I will be happy to either help you get connected to the resource or to share it with you or to find out who in the team knows where to find it. So don't hesitate to reach out if you have any questions. And so I think that we are waiting for the chat, correct, Harmony? Oh, it should be on now. So folks, great. Thank you, everybody. I see Teresa, I see Maurice. Thank you, everyone. Oh, great. Oh, awesome. Yay. Introduce yourselves there. It's great to see those names coming through and that we have the chat. And so, oh, I saw someone from Portugal. Hold on one second. Oh my God, Teresa from Portugal. Bienvenida. Qué bueno. Oh my God, that's awesome. I see folks from North Carolina, from Knoxville, from New London. Oh my God, Charlotte, Boston, West Virginia, Washington, Missouri in the house, South Carolina, Colorado. Oh my God, Indiana, Utah. Oh, Trisha, hi Trisha from Utah. Dallas, Texas, Anchorage, Alaska. Oh my God, Alaska in the house. Indiana again. San Francisco, North Carolina, Michigan. Wow, Southern Colorado. Another California, Wisconsin. Déjame ver quién más. Kentucky. Awesome. Hi, Kentucky. Who else? There's, Ontario, Canada. Welcome, our Canadian friends. Pittsburgh, Pennsylvania, Oklahoma. This is great. Oh my God, this is so awesome to see all these great states coming through. Maine, our friends in Maine. Awesome. I just want to make sure that I'm seeing who is here. See. Atlantic City, great. New York, Western New York, Buffalo, our friends from Buffalo, New York, yay. Awesome, thank you. Keep introducing yourselves there, folks. I do have one question that I would like to ask folks just to kind of kick off this session. And it's to ask folks to type in the chat if you're able to. What have you heard about harm reduction? We're meeting people where they're at. Thank you for that. It saves lives. Thank you, Nicole. It helps us reduce risk. It's evidence-based. There's many pathways. It's low barriers, radical love, saves lives. It's the future. It's restoring dignity. It's love and acceptance. It fights against stigma. It's a best practice. Absolutely. It's radical hospitality. It's empowerment. It's a judgment-free zone. It's providing a safer space. What else? It's pragmatic, realistic, and non-judgmental. And it's beautiful. Thank you. Thank you, everyone. It's nothing about us without us. Absolutely. Great, Brooke. I'm so glad that you're here. This is a great space to learn more, and I'm always excited to meet folks that are interested in learning more about harm reduction. So thank you for joining us and for bringing your expertise to the room and for allowing us to be in community with you. I see promotes autonomy. It helps us listen. It is about wholeness or restoring wholeness for the person. It's about advocacy. It's equitable and empathy for all. Thank you. Thank you, everyone. Absolutely. It is healthcare too. So thank you. We've heard all those things about harm reduction. Some of those things are positive. We've also heard some things that aren't not necessarily true about harm reduction that are out there. And I think part of what we want to do is always clarify and make sure that when we're speaking about harm reduction, that we're really naming that harm reduction is about health and well-being, and creating a space for folks to be able to practice and exercise their autonomy in connection with other human beings and with themselves. And so when we think of harm reduction as an approach, right, the way that we think about it at NHRC is that harm reduction gives us a spectrum of strategies, a smorgasbord, a buffet of options, if you like food analogies, that you can choose from to discuss with your participants, with your clients and your patients, that they can explore and they can think through, and those strategies can help reduce negative consequences that may be associated with drug use, with sex work, and other behaviors, right? And we do that through discussing or thinking through safer techniques. And safer techniques may be, for example, knowing how to use naloxone, or how to use test strips, or how to inject safely if I'm someone who's injecting, or having access to new sterile equipment, having access to condoms, or having access to other safer use tools. Test strips, yes, Claudia, absolutely. And then we have managed use, which is the space where we are thinking through and discussing with folks their experience of substance use. And here, folks are considering shifting or changing their use, right? They are not necessarily moving towards abstinence, but they are reframing the way that they relate to a substance. So managed use may mean using less. Managed use may mean changing the route of administration. Managed use may mean shifting the substance that we're using, right? Managed use may mean reconsidering polysubstance use, right, as a way of being safer. And then we have finally abstinence. And abstinence is part of the harm reduction approach. Many folks that are successful in abstinence are able to be successful in abstinence because they started thinking about it and having conversations with folks through harm reduction programs. And so we believe in abstinence, and we believe that folks can be successful in abstinence if that is something that they are choosing for themselves. The thing that is challenging is when folks are forced into something, because we know forcing people into things doesn't set them up for success, and many times it's not sustainable. And so when we think of harm reduction, I just want to clarify for folks, and I think that many folks in this room know this, that harm reduction contemplates abstinence as a part of its continuum. And if our folks that we're working with want to move towards abstinence, we are there with them along the way. And there are many definitions also of abstinence and sobriety that folks will have depending on their experience. My definition of abstinence or sobriety may be different than Taylor's. Doesn't mean that mine is better, right? It's just that it's different. So I think that's the piece also of autonomy that we're going to be looking at in a second, and giving room for people to be able to discuss with us what abstinence looks like for them in their reality and in their context. Harm reduction is also a movement. It is a movement that believes that public health should be rooted in seeking and advocating for the well-being, the health, the safety of people. That, if we think of well-being as the central piece of this puzzle, that then we are also thinking about how stigma and criminalization of people cause harm. They're the antithesis, right? Is that the correct word? The antithesis of well-being is criminalizing, is punishing people, is shaming people, is stigmatizing people. That harms people. It doesn't promote health. It doesn't promote safety. It doesn't promote well-being. It actually kills people. We know stigma kills. We also know that harm reduction as a movement and as a practice seeks to foster the health and the liberation of all individuals that come across our doors. And that for us to be effective, for us to be able to do our work in a way that is impactful and meaningful, we have to always center ourselves and ask the question, are we really following and uplifting the leadership of those that are most impacted? Because it's that leadership, it's that expertise, it's those voices, the ones that are key to creating transformative change. So the harm reduction practice is rooted also in a movement, in a philosophy, in a way of being, and in a way of seeing ourselves in relationship to others who are around us and in our community. And harm reduction has 6 principles that are the underpinnings of our practice and of our movement. And we won't go into great detail and depth discussing each of these principles, but I do encourage you to visit our website if you're newer to harm reduction, because we have in our website or on our website all of these principles in a very detailed way, with great examples of what each of them can mean for your practice. So the 6 principles of harm reduction, it'll come to you and it will be surprising, right? That participant repeats, it's the word participant is repeated here many times. Because again, we are a movement that seeks to uplift and center the voices of those who we are in relationship with. So our principles are always reminding us that we are in relationship to one another and we're in relationship to the people that we're serving. So in order for us to treat people with health and dignity, we have to be able to believe that the people that we're serving are experts in their own life, that they care about their health, that they care about their well-being, that they care about the health and well-being of their community. We have to ensure that our services are centered in the needs and the reality of the people that we're serving, right? For them to be accessible, for them to be realistic. And in order for us to do that, we need to have participant involvement. We want to hear from folks if what we're building out or what we are offering is really relevant, it really makes sense for folks, or if there are things that we can do to shift and change the services to meet the needs of those in the community. We also want to work from a framework of participant autonomy. We have to respect that people have the right to make choices, that people have a right to determine what happens and what's best for themselves and their bodies. And we also have to work from a place of respecting the fact that we may think differently than our participants or our clients, but this process is not about us, it's about them, right? So how do we work from a place of empathy to uplift autonomy? And then the last 2 principles that, because they're last, they're not least important, are really having in mind sociocultural factors. How is that participant's identity and their intersection of their realities may have an impact in the way that they can or cannot access services, right? How is that person's life experience, the way that they move through the world and how they are perceived and seen, open or shut doors for them? It may be that there's further access to care, or it may mean that there are no services for that person that meets their needs. And so thinking about the impact of social cultural factors. And then finally, we are pragmatic and realistic. And I think that's the piece that I really appreciate about harm reduction. It's like every day that we're having conversations with people, we're talking about the realities of what it means to use substances, what the potential harms, what are the benefits, and we're engaging with people in a space that is safer to have those conversations. And so the principles of harm reduction really give us the opportunity, right, to have something to hold on to allow us to shape and structure our interactions and our work with our clients, our patients, our participants. And then I really want to highlight again this principle of personal autonomy, because to me, it's really, really crucial, not only to the general work that we do as harm reductionists, but also when we're thinking of working with survivors of domestic violence, of intimate partner violence, when we're thinking of working with survivors who are female identified, the concept of personal autonomy to me becomes even much more important and much more relevant in terms of how we can best support those folks. And so the way that for the purpose of this session, we're defining personal autonomy as a person's, an individual's capacity for self-determination and self-governance. It means that when working with people who use drugs, it requires of us practitioners that we respect the choices of the people with whom we're working with. It may not be the choice that Tanagra, Maria, Melgarejo, Pulido, that's how my mom would call me when she was mad at me, to say, oh, my name, I know I was in trouble, would make. But it's essential that we respect the choices of that person as their right. By recognizing also that most often than not, we are just doing the best we can with what we have. People are trying to do the best they can with the tools and resources that they have. And if someone doesn't know about a resource and doesn't have access to that tool, then they can really contemplate it as part of their reality, right? So it's really important for us, again, to work with people, to be open to listening, to learning, and to come from a place of empathy and caring curiosity, right? To be able to really center and uplift this concept of personal autonomy. And then tied to that concept of personal autonomy, it's this other beautiful concept that has been gifted to us by Pat Denning and Jeannie Little from the Harm Reduction Therapy Center. Those of you that are in California, particularly in the Bay Area, may be familiar with Pat and Jeannie's work. And they are the first original harm reduction therapists, right? They were the first set of folks that imbued and infused harm reduction to their therapeutic practices. And in their wisdom, they tell us that when we're practicing harm reduction services, it requires us to be willing to engage in this practice that they have named radical neutrality. And what they mean by that is that we will have to grapple with gray areas. We will have to grapple with things that are unknown to us, that are foreign to us, things that may even confront us with our own biases, right? It is asking us to tolerate, accept, and try to understand what we perceive as difficult or challenging behaviors from participants. It also means that we're open to be taught by our clients, right? And that we're open to relinquishing this role of authority, judge, or expert, because ultimately, we know that in order for us to be successful and to create a safer space for this therapeutic alliance to happen, we have to be willing to partner with our clients, with our patients, or with our participants. And so I think this piece of radical neutrality and acceptance is, how do I show up every day to do this work from a place of self-compassion and also compassion towards the people that I'm going to be working with. And I think it's a really great reminder, right, that this is a great opportunity for me, Tanagra, to learn every day something new about myself, but also to be taught by my clients. And I feel that a lot of what I know and who I am today is because of people that I work with that have gifted me the gift of sitting me down and teaching me, right? And for me to be open to that part of the process as well. So I think when we're thinking of working with survivors, I want us to also think not only about personal autonomy, but think about this concept of radical neutrality and acceptance as we're building out services, as we're trying to figure out ways to support folks that are moving through really complex and complicated and potentially like multiply layered challenging situations. So I'm going to pass it now to my lovely colleague, Taylor, so you can get a rest from my voice, but also so you can bask in his brilliance. And he's going to move us through this section.
Thank you, Tanagra. I love your voice personally. I don't know, give a shout out in the chat if you also love her voice. So we can't really have this conversation, right, about what we deem this new syndemic approach, right, without talking about trauma, which, you know, I think kind of gets thrown around in the cultural lexicon, you know, people talking about traumatic events or their trauma, shared trauma, collective trauma. So I wanted to throw it out to everybody here. What's kind of, if you had to give an elevator pitch on trauma, how would you define that? And I'm not looking for, you know, a right or wrong answer here. I'm just genuinely curious because I see a lot of good stuff in the chat centered on, you know, abstinence and harm reduction and what that looks like and what that means and forging and creating your own road, right? Zachary's just like, hey, it's everywhere, right? Absolutely. The collective weight of negative experiences, something too overwhelming. I love that. Ooh, it's moving so fast. Getting a lot of love for your voice, by the way, Tanagra, which is not surprising, right? Yeah, something too overwhelming to the mind to process immediately. I really like that, Valerie. Yeah, trauma, our inability to accept current realities, a negative event that creates an indelible mark. Brian, look at you using your SAT words. I love that. Negative experiences that affect a person, what happens internally. Yeah, and I like that whole concept and idea of a spectrum too, because we're going to get into kind of like our juicy definition here. Um, but when we talk about trauma, and you can go to the next slide, we're talking about something that results from a single event, a series of events, right? Ongoing circumstances, right? And it's affecting somebody's mental, their physical, emotional, and I would even argue their spiritual well-being, which is something that I think gets left out a lot when we're kind of working with our participants and our clients is just that spiritual component and how important that is. And I love talking about history and harm reduction history. And one thing I always open when we do our whole foundations of harm reduction training is that when we ask people, why do people use drugs? Why don't they use drugs? The spiritual component overlaps and comes through on both ends, right? When we look at certain cultures and it goes way, way back, and drug use is something that's been going on for centuries, right? People have been using drugs and spiritual practices for a long time. Sometimes people don't use drugs because of spiritual practices, right? Certain things they do. So just kind of alluding to that element being really key and foundational here as well. But we're going off of our SAMHSA definition here, right? Because they're talking about something, trauma is something that's experienced physically, is emotionally harmful or life-threatening. And as some people had even mentioned in the chat, it's something that has really lasting adverse effects. And that's what sets it apart from just saying that was a really awful day that I had, or that was just like a crappy thing that happened to me, right? And in harm reduction, we see trauma as often a major factor behind drug use, or things like housing instability or experiences of violence, right? All things we're talking about today. And understanding trauma really helps us to provide more effective and compassionate support, right? We talk about compassionate care and support with overdose and not using high dose naloxone, right? But we also need to really understand trauma in the sense that we need to be supportive of the people who walk through our doors and seek our services. The thing I do want to say though, I want to be really careful and caution people with saying that just because someone's using drugs does not mean there's someone who experienced trauma, right? We need to acknowledge that, as Tanagra beautifully explained earlier, people use drugs for a multitude of reasons. They could use it to maybe stay up at night, to make meaningful connections. I know in my work, we talk about that a lot when we talk about pleasure activism, when we're talking about LGBTQIA communities, right? Um, but again, I think talking about trauma here is really foundational, the conversation we're going to have as we have these overlapping layers of domestic violence, of homelessness, and drug use here. So drilling into that slide, and actually, Harmony, go back for just a second. I'm going to linger there. Sorry, I always kind of go off my script and I get a little verbose, but I just want to make sure people understand these 3 E's as we have, right? So the first one being event. So this could be an overdose, it could be an eviction, maybe an arrest for drug use or an experience of domestic violence or intimate partner violence, right? And the experience is someone how they process or interprets that event, right? So for example, 2 people might have gotten caught up in a sweep, those terrible sweeps that happen at homeless encampments, right? Both people might have gone through that. One person might feel hopeless, where the other person feels like, you know what, maybe I'm going to follow up on that referral or reach out, right? So 2 people could have different experiences of the same event. And then when we talk about those effects, the effects of trauma can be immediate or long-term. It can be complex, right? It could, cause someone to heighten or increase their drug use, or it could change their relationship to use entirely. Another thing I like to remind people is that we have different relationships to different drugs and substances. It's not like it's a blanket thing, right? Like an all or nothing thing. I think a lot of us can agree there. Or this can show up in the way of distrust in services or maybe worsening mental health, right? Yeah, we can go to the next slide. So here, looking at examples of trauma, right? So we have things like experiencing or observing physical, sexual, or emotional abuse, childhood neglect, right? Having a family member maybe with a mental illness or mental health or substance use disorder, experiencing, maybe it was firsthand or witnessing violence in the community, or while serving in the military, things like poverty and systemic discrimination. So it can kind of be on this microcosmic level, right? Or we can zoom out and have more of this macro understanding of trauma. So just to kind of remind people that, you know, these experiences don't just impact individuals, they also affect families, they infect entire communities, right? They impact entire generations, I would argue, and that's something that we also incorporate into this. All right, we can go to the next one. So exactly as I'm saying here, you know, when we talk about this structural, historical, this intergenerational trauma, right? How trauma can be passed through generations. Again, it's not just personal, it can be collective, right? So with historical trauma, you know, we talk a lot in harm reduction about the war on drugs, right? Which we've clearly lost that war. And some people say that we're kind of at this war on drugs 2.0 with the advent of fentanyl, nitazines, right? Exceeding over, you know, hundreds of thousands of people dying per year. The criminalization of homelessness, right? Forced family separations, things like that. How these things have disproportionately harmed very vulnerable and marginalized communities. And I also like to use the term historically excluded, right? Because let's be really real about intentionality. Intergenerational trauma, so families that experience repeated cycles maybe of eviction, of incarceration, or violence, right? And they pass these experiences down to the generations after them. And then when we talk about things like community trauma, that's that collective impact of the criminalization that Tanagra had talked about earlier, systemic racism, housing instability, and you can really see how the war on drugs is carried through today, where we have, you know, this mass incarceration. It's very, very expensive. We have people not being able to access medications for opioid use disorder or access the care that they need for things like HIV and Hep C, right? So really understanding trauma at this level helps us recognize that harm reduction is not just about those individual choices, because I think that's a misnomer and kind of something that when I personally have seen conversations with people that don't really like harm reduction, they'll say, well, it's just people making poor choices, right? And that completely negates collective trauma, collective experiences, whole generations, right, who have experienced these systematic harms and this systemic violence, I would argue, right? We can go to the next slide. So this is just a graphic here. I'm sorry if it's a little blurry on your screen, but again, it's talking about what I just walked us through with that collective, that interpersonal trauma, which again, interpersonal meaning occurring within relationships. So that could be somebody, you know, who's maybe in an abusive relationship while also struggling with substance use or drug use, right? And that individual trauma, right? So that direct personal experience, right? Overdose, eviction, maybe being denied medical care for drug use, right? And what I like about this graphic here is that it talks about, and I think somebody just put it in the chat, ACEs or adverse childhood experiences, right? And at the top, we have this historical and structural trauma, which I walked us through, political and economic trauma, things like homophobia, transphobia, xenophobia, and working all the way down, we have on the right side social and behavioral determinants of health, right? So education status, where you live, right? Neighborhood, built and physical environment. And as you can see, that's why there's not just one nice little package definition for trauma, because it encompasses so many of the things that you're talking about in the chat and so many of the things that we're sharing here. So just a nice visual for people. I'm personally a visual person, so I think it just helps to know that this is really complex, right? And this is just one piece of the pie. All right, so we're going to move on to stigma. And again, just like I asked you with trauma, and I apologize if I'm neglecting the chat a little bit. What is kind of your elevator pitch to people when they ask you, like, okay, people say stigma kills, but stigma, like, what is it? It's not a physical thing. How can it kill anybody? Like, what's the big deal? You know, people shouldn't be using drugs, right? Like, what's the deal with it? I don't understand. Okay, Haley says it's a judgment. Brian says the same thing, right? And Leanna, totally a lie, right? Totally a lie. Socially accepted judgment. Interesting. A mark of judgment, a cloud of shame, it's deadly, right? Social issues, social isolation, stigma is hurtful. Disgrace, it impacts the way people are treated by care providers. Unfounded assumptions. Seen as harmful to the community as a whole. Yeah. I like your elevator pitches. Unconscious bias that allows individuals to treat people differently. Harmful labeling. Yeah, we're gonna get to that in a couple slides. You can go to the next one. Right. So essentially, when we talk about stigma, and I personally love this graphic, we incorporate into a lot of the trainings, but it's essentially a major barrier to harm reduction, right? To things like housing, things like domestic violence and support services. And as someone said in the chat, it refers to that mark of shame or uh, discredit that leads to discrimination, right? So people who use drugs, people experiencing homelessness, and survivors of violence, they often experience stigma when they're just trying to access services, right? So that can lead to things like, I'm not feeling worthy enough. I'm just going to avoid care. Why do I even want to engage in the system? And then what happens is that people further isolate, right? And then unfortunately, a lot of times that results in death. And that's obviously what we want to avoid. So we can see stigma operating at different levels here. So, and also if you see my head on a swivel, I have like the slides open and I have you all over here. So I'm back and forth. But we start on the left with the stereotypes or the ideas, right? So these are overgeneralized beliefs, like assuming that, you know, all people who use drugs, you can insert really any community here, right? Any oppressed community. All people who use drugs are incapable, they're dangerous, right? They cannot recover, right? So that's the idea that gets implanted. And then as we move to the right, we get to the prejudice or the beliefs. So these are the negative attitudes that are based on stereotypes, like believing that, you know, oh, this person is no good, right? They're scary, they're shameful, they're less than, right? They're not deserving. They made bad choices. And as we move to the right, what this results in is the actual discrimination or the action itself. So that's maybe denying someone a job, denying someone housing or medical care, right? Based on their drug use or maybe their housing status. Because a lot of times it's not just one thing. Again, we're talking about a syndemic, we're talking about that overlap here, right? And this, what's interesting too about the discrimination element of this is that you have the structural and the social. So it's not just your peers saying, you know, I don't want to live next door to someone who's using drugs all the time. It smells, they're loud, the whole thing, right? It shows up, like I said, in employment. It shows up in these large structural systems like the medical care complex, right? Maybe someone doesn't have insurance, they don't know their insurance lapsed, whatever it is. Then just kind of reinforcing the whole thing from the beginning, right? All of these reinforce that systemic oppression. Next slide. I see a lot of good stuff in the chat again. Brooke, I'm so sorry to hear that. Thank you for sharing that. And I love how empathetic our attendees are and people in the chat. This is beautiful. So just to kind of really wrap up this part here, right? Stigma at its core is a social process, which reinforces relations of power and control. So going back to that graphic, I think is a perfect encapsulation of this, showing how people get caught up in something and feel like they have their agency, their autonomy taken away. Ding, ding, ding. If you're like, whoa, that appeared in the principles, that's why we define it as such, because we really can't do any of our work without incorporating those 6 principles into what we're talking about here, right? So stigma is not just about personal biases. It's reinforced by these systems and by these policies, right? So it leads to what we call status loss and discrimination for the stigmatized. So status loss meaning like, you know, someone feels degraded, maybe they lose employment, they lose connection with their family, they lose connection to resources, right? They get further pushed away and further ostracized, right? And what I'd be interested in knowing from all of you before we kind of move it forward is, what are some strategies that you all utilize in trying to reduce stigma in your work? I know it's a really big question, but I think you might be surprised that some of you do the same things, or maybe you'll pick up on something new from someone in the audience, right? Oh, yeah. Use solutions focused language. I love that. Person first language. Yes, we're very big on that. Absolutely. Yeah, which is why all the tough love doesn't work, right? It's just a code word for stigma. Absolutely. I heard someone beautifully sum it up the other day saying that rock bottom doesn't exist. Rock bottom is really that person no longer being with us anymore, right? And we want people with us and engaged. Combating misinformation, replacing judgment with empathy, radical acceptance, absolutely never having an expectation of what someone will say and do. As Tanagra said before, and I love the food analogy, it's really a buffet, right? We're just presenting the options and we're letting that person pick and choose on their terms what works for them. And also realizing that that's probably going to change over time, and that's okay. We're not static, we're not fixed in one place. Ongoing education, always believing my clients. I love that, Brianna. So simple, but so effective. Yeah, being curious. I love that. Yep, as someone says, rock bottom has a basement. Asking questions, being willing. These are great. All right, we can head to the next slide. I believe I'm going to toss it back over to Tanagra, but thank you everybody for indulging me, and I'll be sticking around.
Thank you, Taylor, and thank you everyone who has been sharing in the chat. And also, I just want to honor those of you that have lost loved ones. We bring them in this room, we hold them close to our hearts, and this is what we do, as someone said, the work that we do. One death is one too many. So now we're going to transition into women using drugs, right? And I want to ask folks to, again, if you can, type in the chat first, what are some of the harms that can come from using drugs? What would be some of the harms that you have seen or heard shared with you by participants, by clients, by patients, in our own personal experience? We see death. Hold on, it goes fast. You're right, Taylor. We see death, loss of relationships, prison, HIV and hepatitis C, infections, impaired judgment, unconsciousness, broken relationships, health complications, overdose, social isolation, disease, criminalization, trauma, dental issues. Thank you, Monique. Some folks can get infections, cancer, death, wounds, harm not only to oneself, but others. Yeah, sometimes the impact is individual and also, as Taylor was saying, interpersonal and collective. Losing child custody, overdose, losing jobs, losing trust, a medical crisis, complications, disease transmission, soft tissue infections, the financial problems, loss, health and relationships and work, loss of children. It leads to other behaviors that, because they're within the legal realm, they can even be more harmful, right, or more risky. CPS involvement with child protection services. We can have some folks that experience using while pregnant, and there can be fetal alcohol syndrome, loss of brain functioning, loss of self-esteem, trauma, organ failure, IPV, interparent partners violence, general isolation, which is really pernicious, money loss, disease transmission, loss of housing, diminishing supports and systems, illness, homelessness, sexual assault, losing family, jobs, houses, friends, self-esteem, isolation, disconnection, social stigma, etc., vulnerability, loss of support system. Oh my God, there's a ton of stuff that you're all saying. Thank you. I want to ask folks, and thank you for sharing those, if there are specific harms from using drugs that can come to survivors of domestic violence. Out of these harms that we've mentioned, are there some that you would think are specific to survivors of IPV, of intimate partner violence? Depression, coercive control, homelessness, isolation, suicide, fear of coming forward due to drug use and children. Absolutely, Dina. Brain damage, we stay longer in the relationship. We have a fear of leaving or not figuring out a way to leave a relationship or a situation that may be dangerous for us. PTSD, worsened hypervigilance, returning to that relationship. Oh, absolutely. Money coercion, Yesenia, which is financial violence. Absolutely. Hold on 1 second, because I'm trying to like keep up with everyone here. Let me see. Some folks may experience suicidal thoughts, related issues to childcare issues or children, codependence, decreased self-esteem, financial insecurity, severe anxiety, gaslighting, traumatic brain injury. Brianna, absolutely. For some folks that experience IPV, that's something that can be particularly dangerous for folks. and have many implications that are also related to substance use. Absolutely, loss of freedom, lack of trust. Thank you, everyone. So thank you for sharing that, and thank you for sharing some of the harms, but specifically how those harms may impact survivors of domestic violence. So we know, right, that sexism, inequality, and discrimination against women in general, they intersect. And because of they intersect, they also exacerbate the harms to which women who use drugs are exposed to, right? So when we're thinking of working with survivors of intimate partner violence, it's really important for us to come from a place of care and curiosity and to ask ourselves why someone in this situation may seek substances or using substances as a way to navigate and deal with that relationship, right? To think about what would be behind that substance use and how being a survivor of intimate partner violence and how being a survivor of intimate partner violence that is also female identified, how do those things come into play and impact that particular situation, right? And there are several compounding factors that we're going to look at right now that are important for us to keep in mind when we're working with clients that let us know that they're navigating a situation of domestic violence, right? So we know that women experience higher rates of intimate partner violence than that's not that men don't experience them, but clearly women experience higher rates of intimate partner violence. We also know that there are experiences of violence around police abuse, physical abuse, and sexual abuse that female identified folks experience. And we know, as someone said, or many of you said in the chat box, mentioned in the chat box, that folks may be reluctant to access harm reduction services, even if when those services are available, because of fear, right, of what the implications would be of accessing those services. Because if I go to a harm reduction program, I may be coming out as a person who uses drugs, and that may not necessarily feel safe to me, right? It may have implications if I have custody of children or if I'm caring for other folks in the home, or it may mean that if I access those services, I may run into the person in which I'm involved in this domestic violence situation with, right? So all of these things are important pieces for us to keep in mind as part of this puzzle, right? We also know that 1 in 10 men and 1 in 4 women will experience domestic violence at some point in their lives. And these are really sobering statistics when we think about them. Think about the fact that this is a reality for many of our participants, our clients, for many of us ourselves, if we're survivors of domestic violence, right? That about 50 to 60% of substance abuse co-occurs in domestic violence situation cases. And we also know that 72% of murder-suicides involve a domestic partner. So these are really, as I was saying, sobering statistics that can help us get a clearer view of this intersection of intimate partner violence or domestic violence and substance use. There are higher rates of domestic violence among women that are accessing substance use disorder treatment. And we also know that when you're victimized by a partner, it increases our risk for depression, as you all said, PTSD, substance use, and suicidality. So it really is putting us at risk. It's really putting us in harm's way. So when we think of substance use disorder and survivors, it's important to think that survivors that are experiencing substance use, they do so for a broad variety of reasons, right? To deal with the experience of violence, to navigate that situation of violence, to potentially either disconnect or connect to this partner that they are in relationship with. It can be a coping mechanism. It can be used to deal with the pain that comes from those injuries, where there's physical pain or emotional and psychological pain. So it's also another something that is related to PTSD and the person addressing their PTSD symptomatology through using substances, right? And so it is a condition that is developed after someone experiences trauma. It's not a choice, right? So when we're thinking about supporting survivors, it is fundamental that we think about this, and we're very clear that this is something that the person is experiencing, most likely connected to that experience of trauma. If we also have survivors that have experienced traumatic brain injury or other kinds of violence, right, that might also impact the way that they relate to substances. It impacts their health, it impacts their cognition, right? So it is never as simple as saying to someone that you need to quit cold turkey, right? It's never a survivor's fault. I think that that piece is really important. You know, it's like if we could all stop using drugs so easily, we wouldn't be having a conversation about harm reduction, right? We wouldn't have the need for treatment. But the reality is that, as Taylor was saying earlier, and it is a complex issue. It is multi-layered. It is complex. It is intersected by societal conditions, by political conditions, by personal conditions, and so we need to treat it and address it and look at it in all of the complexity that it is exhibiting, right? So what could be some of the reasons why survivors turn to substance use? I think you mentioned some, but if folks can, I think staying awake, what else? What could be some of the reasons survivors turn to substance use? To cope, to forget, to numb, to escape from reality, to address their passion, to deal with the stressors, to dissociate, to have fun. Yeah, for some of us, it's to have fun, to not feel pain, to feel good, to protect ourselves, absolutely, to feel joy again, to be able to regain pleasure. Yes, absolutely, to feel relaxed, to feel accepted, to stay well, to quiet the mind. Oh, I love that, Samantha. If I have a, ¿cómo se dice? I have a monkey mind. So I can identify with that. My brain is going 1,500 miles an hour. To what else? Let me see. To escape, to connect, for community, Matt, absolutely. Many folks name that substance use, the actual pleasure, or like what is positive about substance use, is the sense of connection to community that they get. It's not necessarily the high, right? It's the thing that I find a community here of people that can accept me, that can hold me, that can see me, that can protect me. So absolutely. To find courage, unease, absolutely. To connect to others, to even out, absolutely, to heal. Some folks are born in it, right? So for some of us, we go to something that feels natural to us because it's something that we're used to, because it's something that we've seen. To regain control, Joe, absolutely. To socialize, yes. Some folks may be forced, right? Some folks may be turned to substance use because it is part of what they've done in relationship with a partner, right? Not all substance use in domestic violence situations is coerced, right? There can be coercion around substance use, but we can't assume because someone is using substances and they're in a situation of, in a relationship with someone, that there's domestic violence, that the substance use falls under coercion, right? So I think that is important to think about. Ask the person directly, right? Like, what does your relationships to substance use looks like? And always ensure that people have the tools that they need to be able to use safely. One of the things that I always said to participants is, if your partner is the one that prepares the shot, right, and administers the shot, what would happen if he wasn't around? What would happen if he fell ill? What would happen if he left? What would happen if he was in jail? How would you be able to ensure that you're able to get what you need and be well? So I want to teach you how to do this so that you have the skill. If you don't need to use it, you don't have to use it. But if you need to use it, you have it, right? And that gives a sense of empowerment to the person as well. Sometimes it is about pleasure in partnership, to use substances with someone else. And some folks have articulated that they derive pleasure and contentment from having their partner prepare the shot and administer it to them. And for some other folks, it's like, this is the way that that person gained control over me, right? So all of those things can be true. We can make assumptions. It's always important, as Taylor said, to ask questions, to seek clarification, to ensure that we're hearing the voice of the person, the participant, the client, and the patient. So survivors can turn to substance use for a multiplicity of reasons. It can be a coping mechanism or an escape from trauma. It can give us back our sense of control, our sense of autonomy, of empowerment. It can help us by reducing feelings of isolation and loneliness. This is the piece of community that many of you were mentioning. It's a way to self-medicate, to quiet the mind, to disconnect. Sometimes, I get, I don't know if this happens to you, but these days, I feel like I just want to shut my brain off. And what I do is I go back to watching The Sopranos, which is my favorite show ever. And that's my way of shutting off my brain. Oh, Claudia, yeah, we need to talk offline about that. 25 years later, I like going back to The Sopranos and I'm like, oh my God, Tony, I missed you, right? So for some other folks, it may be exercising, or it may be, meditating or practicing yoga or swimming. But it's that kind of self-medication can look many different ways. It helps us to boost our confidence and our self-esteem. And also it can help us, as I was saying, to dissociate, and to dissociate particularly because we're experiencing shame and stigma, not only because maybe we're using substances, but also because we're being shamed and stigmatized because we're in a situation of domestic violence. How many times have we heard folks say, oh, why is she staying in that relationship? Why isn't she leaving? Why is she choosing to continue, right? Why didn't she leave before? I heard that in my own experience of domestic violence. Like, why did you stay so long, right? So all of that shame and stigma that we feel because of the situation of domestic violence may also be something that we're holding, and using substances can help us to feel less of that pain, less of that shame, less of that stigma. So we always have to also remember, right, that survivors of intimate partner violence, survivors of sexual violence, many of them don't touch substances and don't develop substance use disorder. Folks that experience substance use disorder may have never experienced situation of violence in their lives. And we also know that there's an intersection of folks that both experience sexual or domestic violence and substance use. We can't make assumptions, as Taylor was saying earlier, about a person's reality. I think that what harm reduction gives us, a lovely gift that this framework and movement has given us, is the ability to build relationships with people. And the way that you build relationships is through communication and through trust and through asking questions and clarifying our assumptions, right? But there's also studies that show that for some folks in that intersection, the reality is that domestic violence, sexual assault, sexual abuse, and substance use can be a place where they meet. And I wanted to share with you this tool. I don't know how many of you are familiar with the Duluth. I'm going to pronounce that in my Spanish, from my Spanish, English with Spanish accent. I apologize. Duluth, these folks in Duluth developed a framework of the power and control wheel. And I will ask Harmony to help us find that tool so you can have it. And out of that, folks have been adapting and building out new tools or new wheels, power and control wheels. There's a great power and control wheel for folks that are supporting survivors that are immigrants. There's a great power and control wheel when we're working with folks that are in LGBT, lesbian, gay, bisexual relationships. There's a great power and control wheel that explores power and control specifically in the financial realm. And then we have this power and control model for folks that are women identified that are also using substances. Thank you, Harmony, the Duluth model. And you can learn more about the Duluth model. Some of you may know about it, but I encourage you to go. They have all of these wheels, they have them available. And what is really lovely is that you can find the wheels and you can find them in different languages. So if you're working in communities where you have folks that are coming from different places and different cultures, you may be able to have access to those wheels in the language that they speak so that they can connect to it better. So if we see this power and control model for women who use substances, we see that there is economic abuse and the ways that economic abuse shows up. by keeping them dependent financially, by preventing them from getting a job, from making them ask for money or taking their money, etc., using threats and psychological abuse, using emotional abuse, physical abuse, isolation, encouraging drug dependence, introducing that person to drugs, buying the drugs for the person, which is tied to that economic abuse, encouraging drug use or drug dependence, right? Not letting the person access services on their own, or not learning or not giving them room to learn how to use the drugs themselves if the person introduced them to substance use, right? So here, I just love this tool because this is a visual way for us to create a space for conversation with survivors that may be also experiencing substance use. And I also want to name that when we're working with survivors, it's really important for us to keep in mind what may be some of those barriers to services that they may be experiencing. And there are structural barriers, like we saw with stigma, and there's also personal barriers. And some of the structural barriers could be their caretakers' lack of access to childcare or to care in general for other dependents. Some of our services may be in unsafe or indiscreet locations. Like I'm going into a space and everybody knows why I'm going there, right? If I'm the only game in town. Sometimes the service schedules can be really rigid. There may be long waits or bureaucratic hurdles that people are experiencing. And there may be a lack of sufficient service provision. The services that are provided are really limited, right? So they don't meet the needs of all the survivors that may be trying to access them. And then there are personal barriers, right? I think some of you mentioned fear of partner violence, fear of losing children or dependents to government bodies, personal and financial concerns, and fear of losing their partnership. These are maybe some of the barriers that survivors may experience when trying to access harm reduction services and or domestic violence prevention services or intervention services. And so what we see is that the person is experiencing victimization, they're experiencing violence, there may be a trauma response there. We use substances to help us navigate that trauma response. And then that substance use and that trauma response and the lack of supports may put us at increased risk. And then that cycle perpetuates itself, right? So how do we break that cycle? How do we step in to support, to provide supports, to provide space, to hold space for these survivors, right? And part of what we want to do is to think about these compounding factors and how those factors impact our participant. So when we think of, the compounding factors around, domestic violence and substance use, what do you think are the factors that our participants may experience the most, and how are they impacted by this? Do we see other disparities that we haven't mentioned in terms of working with survivors of intimate partner violence who also use substances? Yes, thank you, Haley. Folks are having a hard time maintaining or keeping employment, so that keeps them in that loop of financial dependence. The lack of ability to access behavioral health services, being unhoused, being homeless, dependency on their partners, right? The partner in which the abusive relationship is happening and having access to that substance. The finances, that financial insecurity is huge, and more so in this day and age, right? Because from financial insecurity, all these other things that can potentially put people in harm's way stem from, right? Like lack of access to housing, lack of access to employment, lack of access to healthcare. It impacts your ability to keep or maintain custody of your children, right? To access legal services, healthcare, self-doubt, trust in others, shame, absolutely fear. Thank you, Monique. Self-doubt, financial insecurity, yes. Here, I want to say it's there's a compounded lack of empathy because of the stigma, both from staying in the situation of domestic violence and using a substance. Begins to be framed as deserved instead of understanding the experience. Absolutely, Shelley. Thinking about, not necessarily being able to address mental health needs. not having immigration status. Thank you, Rosanna, absolutely. And one of the things that I want to name is that many of, like, when we think of like, oh, someone wants to get treatment, but the reality is that all of these systems are built out from an androcentric perspective. And what that means is that they're built out to meet men's needs, with men's needs in mind. And in this patriarchal society, most of the time, we don't think of men, which is mistaken, and it should not be that way, that men are not the ones that are taking care of the kids, right? That they are not responsible for those things. And because of that, we don't think about the fact that maybe we need to consider childcare, or maybe we should consider inpatient services or outpatient services, right? That really meet the needs of folks that are caretaking, right? That if we're creating services that are built out for women survivors of and folks that are using substances who are female identified, for example, and they have uteruses and they're menstruating, that maybe want to have like just basic reproductive health and sexual health and menstrual health services, right? So we're thinking about those things that feel really simple. The reality is that all of those things become barriers for people to access those services and to feel that they can be successful in committing to and moving through the service provision. Thank you. Androcentric, yes. So now we're going to move into looking at housing and working with survivors, right, who use drugs, and what are the opportunities for engagement and harm reduction, right? And so I just want to remind us all that 1 in 4 women and 1 in 10 men have reported some form of intimate partner violence in the lifetime. So I want us to remember that this is a more common occurrence that we know, that many people do not report for many different reasons, that sometimes they report it and whoever is taking that report doesn't channel it or categorize it in the appropriate way. So we know our data can be flawed, but these numbers tell us a story, right? And some of those effects include physical trauma, psychological impacts, developing mental health conditions, substance use, and financial troubles. These may be some of the things that may come out of this intimate partner violence situation. We also know, as we were mentioning, that women face unique obstacles to services and treatment because of androcentrism, what we were talking about, the systems being devised through the worldview and the needs of men and not necessarily taking into account the needs and the realities of women. And we know that they also face heightened discrimination and stigma, lack of childcare, and treatments that have worked for men, but we don't know if they work for women, right? That's the other piece that is important here, right? We haven't done a lot of studies with only female subjects around this. And we also know that although men are more likely to use drugs than women are more often affected by substance use than men, and more affected negatively by others' use, right? So the price that women pay for their use is higher in many ways than the price that men pay. And I'll give you an example. I had a program participant that I worked with here in Puerto Rico, which is where I'm based out of, and her partner both used drugs and both were arrested and both had criminal charges brought against them. They also had children. In his case, the court allowed him to continue to have visitation, weekend visitation with his kids, where the kids could go to his house and he could have them. In her case, she was denied all visitation. She wasn't able to have any relationship with her children. And the only reason that I can think that that decision was made was because she was a woman. And because in this system, women who use drugs are considered bad mothers and bad people, right? And so, and I see other people echoing this, right? So again, these are the things that we need to keep in mind, because these systems are not fair, because they're not built to be fair, because they're built to meet the needs of a specific group of people and leave out the rest. So for us as providers, if we keep that in mind, we can then become advocates, but we can also create spaces of conversation with folks, and we can figure out ways in which we can support that participant, right? Women
Tanagra,
who
one
use
thing
substance.
really
See,
quickly.
go for it,
Oh,
Taylor.
sorry.
No,
I know
no,
you're
go
in
for
your
it.
flow.
No, no,
One
go for it.
thing that I think it's probably come up, maybe I've missed it because we have like over 400 people here, but I think what also makes this really difficult is that even though when we open up spaces for dialogue, right, and support with people, a lot of us are tethered to the mandated reporting title, right? And that's where
Yes.
things get really complicated. There are a great number of resources out there about how to navigate that. But I'd be interested too if people in the chat have found ways to kind of work around and to incorporate certain strategies to work through it. Because I know as myself, and I'm sure you have this experience as well, as someone who is a mandated reporter, and I see L, especially with minors, right? That
Yep.
intersection with minors, very difficult, right? There are ways to work through it, but I think my point is that further isolates people from the resources available to them because they'll say, well, if I really tell my whole story, I'm going to get implicated. My children are, maybe I have a warrant or I have a prior arrest or something, and they're going to look at me like I'm a bad mom, a bad parent.
Yep.
So just acknowledging that element as well.
Yeah. Thank you, Taylor. One of the things that we did at the program that I worked at, for example, as a social worker, I am in Puerto Rico, by law, I'm a mandated reporter. But someone who works with me, like another case manager who's not a social worker, they're not bound by the same covenant, right? So they don't have to, they don't, if someone has a conversation with them about substance use or about any of these things, the way that they can provide support is different than the way that I can. Like if someone tells me something, I may have to, again, and this is grappling with those ethical gray areas that we were talking about earlier, that Pat Engineer reminding us. So one of the things that I said to participants when we were starting our process was, these are the conversations that I can have with you. And these are the things that I may not be able to necessarily talk with you at length because of this situation. If you want to talk about those things, you don't need to tell me. You can just go ahead and have a conversation with another of our counselors here who can hold that space for you. And that way, I am protecting myself, I'm protecting her, and I'm creating a safer space for that conversation so that she can actually get the services that she needs and the supports that she needs. And I think also, Taylor, I see other folks are sharing here. I think if folks have resources that you want to share, you can link them in the chat. Absolutely, because I think that that's an important conversation to have. And I think that there are ways in which we can assure that we're protecting the minors, protecting the parent, and also minimizing potential harms as well. Thank you for lifting that up, Taylor. I think that that's really important. And I see other folks are sharing in other parts of the world, it also may look different. And sometimes I think hearing about what other folks in the world have to deal with or experience can help us see, gain some knowledge so that we can maybe bring some of those strategies. And so things for us to keep in mind in terms of women and substance use. Again, there's not enough data on drug use and women. Data assumes also that women are cisgender. So that means that we're not looking at the broad spectrum of who women are in the world, right? There's not enough data on queer women who use drugs. And many of the studies that we have found just jumble all folks that are within the LGBTQI plus community together. And our data is also not inclusive on trans women. And so our studies give us information, our data gives us some information, and then our programs are built out on data. So no wonder why sometimes we're leaving people out, right? So what we want to see is hopefully more studies that are really diving into the different experiences of women, right? And women from different minorities as well. So when we think of housing and we think of survivors, I just want to remind us that housing is a human right, that it's a human right that folks should have, although we also know that housing is under attack in many parts of the world and in this country. That we want to make sure that if we're providing housing, we can also include harm reduction services into housing, that we want to engage people actively without coercing them into services, because we know coercion never works positively for the long term for people. We want to make sure that when we're planning with participants, we're centering the planning around their needs, and that it's person-centered and not driven by metrics or deliverables, that we're really looking at the human being. We're rehumanizing services. We forget sometimes, I mean, I don't forget, but like systems forget that we're working with people. We're not working with machines, we're working with humans, right? That we should separate housing and treatment, that housing should be standalone and treatment should be separate, in the sense of like, I am not going to hold your housing contingent to whether or not you go into treatment, because that could be detrimental to a person. All of our services should be focused and orientated around recovery and what recovery looks like for that person and that individual. And we should try to make sure that our services are low threshold and flexible, right? And offer them as long as they are required, right? That ideally, that's what we want to see, right? So it's always housing first and not housing only, right? Harm reduction center housing services is not only a philosophy, it is a practice, right? That values flexibility, provides individualized support. So that means that it's not a one size fits all, that is looking at each person that is receiving that services and really focusing what they need. It really honors and uplifts participant choice. Remember, when we're talking about participant autonomy, and it has never been housing only, and it never should be, right? Housing, to be successful, should also be entangled with supportive services, right? And they should be part of that practice, and they should be offered to folks, and folks should be able to determine which of those services they would like and which of those services they're not interested in the moment, right? So it can be formal and informal supports that we offer, both like such as doctors or therapists or social workers or group supports, or connecting folks to family and friends or faith groups. So it's really about giving people room for exercising autonomy and having room to make choices. Again, that's smorgasbord of services, because if I can make a choice, I'm regaining my power, right? If I can decide what I want, I feel like I'm being trusted, that I'm being seen, that I'm being heard. Support should not be prescribed. We want folks to be able to choose what they want. Again, I want it by case scenario, and make sure that we're not making assumptions that what works for one participant or what one participant wants is what the rest are going to want. We want to ensure that we're creating room for each participant to practice their autonomy and to build out their resilience. So for us, when we think about our harm reduction principles, now we're going to look at the harm reduction principles centered in housing, right? So we want to make sure that we're building not only spaces for participants to exercise their health and to also be treated with dignity. We want to make sure that those services are participant-centered, that we're giving plenty of room for participant involvement, that we're also building low threshold access to housing. And by low threshold, it means you need housing. We can offer you housing, right? Individualized client-driven voluntary services. I had many participants who, when they came in the beginning, all they wanted was housing. And then it was my job to make them fall in love, hopefully, with our services. And eventually, when they started coming around and they didn't feel pressured or pushed into anything, 99% of them ended up taking advantage and using and really engaging with all the different services that we had to offer in a voluntary way. But it was because we didn't push them. We just told them, if you're ready, great, and if you're not, you still have the housing, and we're here for you. And then make sure that we are always, again, protecting and centering and uplifting that client choice and that space for self-determination that is so important. So what can you provide? We can provide trauma-informed housing services that are rooted in harm reduction, right? We want to also start shifting this idea of, when we're offering trauma-informed care services, instead of thinking what's wrong with people, we should ask what happened, right? What happened? What is happening? What is going on, right? It's shifting that thing of like, something is wrong with what is happening, what is systemically impacting you, that it's leading for these situations to be manifesting, right? And so instead of being problem focused, we want to be trauma informed focused, right? We want to work from that perspective. I think someone mentioned in the chat box this, right? So thinking about how do we provide services from a trauma informed perspective, right? And I always assume, and what I do is like, we should always, all of our services should be trauma informed, period. End the story. All of our services should be harm reduction centered. Period. End of story, right? Because it makes sense, because it's easy to do, and because it benefits everyone, right? It benefits every single person that we're working with, whether they use drugs or not. Because harm reduction is love, harm reduction is empathy, harm reduction is compassion, harm reduction is centering the expertise of our participants. Harm reduction is about building connection and relationships, and the same thing comes from a trauma-informed perspective, right? So at the end of the road, it's better for participants and better for us if we're able to offer our services through those lenses. And harm reduction services is so much more than just handing a syringe or handing a cooker, right? What I love about harm reduction is that you can practice harm reduction every day through all of the things that you do, right? And you can do so by offering referrals to people, by providing housing access to people, by giving room for people to come to a drop-in center. I have to tell you, one of the things that I have loved the most in my career is to be able to host drop-in center spaces for participants. They're chaotic, they're messy, and they're my most favorite place to be. And I love that because folks can come in and they can sit down, they can relax, they can rest, they can get some food, they can get some water. Some of our drop-in centers used to have lockers for folks to drop off their stuff and be able to go run errands. For some folks, it was about taking a shower, brushing their teeth. We had areas for folks to rest and relax, to use the computer, to use the phone. It was just such a great community space. And not only participants from our program used our drop-in center, the community as a whole used it. We hosted community events there. So it was really embedded in community and really protected by community, and that was really beautiful, right? And other things such as safer sex materials, medication for opioid use disorder, legal referrals, all of these things are part of the harm reduction services spectrum. Sometimes when we think of harm reduction services, we only think of handing out syringes and cookers, but it's so much more than that in terms of what we believe harm reduction services are and can be. And we always offer our harm reduction services through this lens of trauma-informed care. And we always hold dear the 6 principles that are very similar, if not parallel to harm reduction. The principles of harm reduction, because we're ensuring that we're creating safer spaces. We're building relationships rooted in transparency and trustworthiness. We are creating spaces for peer supports and for mutual self-help. We are also working in collaboration and creating spaces of mutuality as providers and participants. We're giving room for empowerment, voice, and choice, which is nothing different than participant autonomy. And we always, always, always center cultural, historical, and gender issues, because those things impact persons' capability and ability to access services. And so what we're talking about is to moving into a healing center engagement approach. And this is a model that was created by an African-American psychologist named Sean Ginwright. We're going to look at him in a second. And what he's saying is that we have to take into account several things: people's culture, and thinking about how do we have conversations about a person's identity that are restorative. We have to think about giving room for people to build solid and strong relationships, creating spaces that allow people to not only be vulnerable, but also for them to feel empathy and to be empathetic towards others. A space for us to reconnect to our meaning, who we are, what is our purpose, who do we want to be, why are we here on this earth, right? To be able to have aspirations, to set goals, right? Our own goals, not the goals that have been imposed on me or told to me that I should have. And that leads to agency, right? We want to develop voice, a choice, ability to make decisions for people. These healing center environments are crucial when we're thinking about providing housing to survivors of intimate partner violence that are also folks who use drugs, but I think healing center environments should be a practice for all of us that are providing services to other people. We want to make sure that people feel welcome, that people feel seen, that people feel heard, that people feel that they can be their most true, honest self with us, that they're not telling us what we want to hear, but ultimately that they're telling us what is really happening so that we can actually be effective in supporting and working with them. Many times, you know, folks are scared of telling us, as Taylor was saying, what's really happening, because it can have serious implications. They can lose a lot or lose more than they have already lost, right? And so we want to make sure that folks can be truthful and transparent and feel safer in doing so with us. So as we're wrapping up, I just want to name that when we're practicing both the principles of harm reduction and of healing center engagement, we have access to a series of tools that allow us to release ownership over another person's outcome or process. It gives us the ability to honor, as Dan Big said, and our harm reduction parents said, honor any positive change, and to center the autonomy and self-determination of every human being, and that's treating people with dignity and with kindness. Because ultimately what harm reduction does is give us the greatest gift, is to give us freedom, to be authentic, to be transparent, to be able to connect and learn and be in relationship with each other and with our clients and with our community. So I'm going to stop here. I'm going to stop sharing my screen because I'm going to share with you the slides. And I want to make sure that you have access to them, those of you that are still here. But we have some time if folks want to ask questions in the chat, you can do so. If you want to give us your thoughts, opinions, anything that you want to tell us, we would love to hear from you. Let me just paste this here. So you have access to the slides there. And I'm going to type my email.
If folks want to come off mute, you can just raise your hand.
Oh, thank you. Oh, thank you, Harmony. Yeah, if folks want to use their microphone and we would love to hear your voice, feel free to do so. You don't have to, but you can. And we can stop recording, I think, Harmony, also. I just want to thank everyone.